My name is Eric Mitchell, and I'm the Executive Director of the Alliance to End Hunger. The Alliance is a coalition of nonprofit organizations, corporations, foundations, and others. And our mission is to engage diverse institutions to build the public and political will to end hunger in the US and around the world. We're excited to be hosting today's panel with the Black Women's Health Imperative, and we are so glad that you are here to join us for this important conversation. Before we begin, just a few moments to take some housekeeping notes. Today's event is being recorded and will be shared with participants in the next few days. We invite you to share your comments and relevant links or publications in the chat at the bottom of your Zoom screen. Please use the Q&A box for questions that you may have, and it would be great if you could state your name and affiliation when asking your questions. Please feel free to ask questions at any time during today's event. Panelists are welcome to respond to questions in the Q&A box or offer their comments in the chat box while they're not actively speaking. If you run into any issues with your video or audio, please leave the event and try logging back in or connecting your audio by phone. Every day, healthcare providers across the nation see the effects of maternal and child nutrition. That's because pregnant women, new mothers, and young children everywhere need sufficient food and good nutrition in order to thrive, especially during that critical period of the first 1,000 days between a woman's pregnancy and a child's second birthday. Newborns who are food insecure are more likely to be underweight, often leading to lifelong development and chronic conditions. Hunger affects children at every age, from birth through the end of life. We know that access to adequate nutrition is critical for healthier pregnancies, improved birth outcomes, and healthier growth and development for young children. That's why healthy nutrition programs can be the first line of defense to ensure positive health outcomes for mothers and their children. In the US, the two federal nutrition programs that help to benefit mothers and children the most are the Supplemental Nutrition Assistance Program, often known as SNAP, and the Special Supplemental Nutrition Program for Women, Infants, and Children, also known as WIC. Both are critical to health and nutrition for pregnant women, mothers, and children. And nearly half of all Americans who use SNAP program are children. And the WIC program has bridged the gap between medicine, food, and nutrition better than almost any program in the United States. While research is still needed to document WIC's important impact on Black women's maternal mortality rates, we do know that national aggregated data shows that WIC contributes to healthier pregnancies, improved birth outcomes for low-income women and infants, and healthier growth and development for young children. This program has also been a tool to create more equitable outcomes. For example, breastfeeding support provided through WIC has proven effective in addressing racial disparities in breastfeeding rates among Black women, and the food provided through WIC works like a prescription, providing nutrition interventions which can reduce the likelihood of preterm birth, low birth rate, infant mortality, birth defects, and childhood obesity. Today, we will have a more in-depth conversation about how investing in these programs can help foster better health outcomes for pregnant mothers and their children. But before we begin, we are excited to share remarks from Congresswoman Lauren Underwood. Congresswoman Underwood serves the Illinois' 14th Congressional District and is the first woman, first person of color, and the first millennial to represent her community in Congress. She is also the youngest African-American woman to serve in the United States House of Representatives. Congresswoman Underwood currently sits on the House Committee on Veterans Affairs and the House Committee on Appropriations. She is a member of the Future Forum, a group of young Democratic members of Congress committed to listening to and standing up for the next generation of Americans, the Congressional Black Caucus, and the LGBT Equality Caucus. Congresswoman Underwood co-founded and co-chairs the Black Maternal Health Caucus with Congresswoman Alma Adams from North Carolina. This caucus elevates the Black maternal health crisis within Congress and advances policy solutions to improve maternal health outcomes and end disparities. So without further ado, let's take a moment to hear from Congresswoman Underwood.
Hi, everybody. I'm Congresswoman Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District. I'm excited to join you for this important conversation about our nation's maternal mortality crisis, which disproportionately impacts Black mothers and other women and birthing people of color. It's unacceptable that the United States, the wealthiest country on earth, has the highest maternal mortality rate in the developed world. And for women of color, the risks are even greater. Black moms are 3 to 4 times more likely to die from pregnancy related causes than white moms, and Hispanic, Asian, and Native American birthing people also experience elevated risks of mortality and morbidity. As a co founder and co chair of the Black Maternal Health Caucus, I'm committed to the critically important mission of advancing legislation to save moms' lives and racial and ethnic disparities and achieve true equity and justice for all. To address the root causes of maternal mortality, morbidity, and disparities, we need data driven, evidence based policies that center the voices of families impacted by this crisis. That's why in February, I introduced the Black Maternal Health Momnibus Act with Senator Cory Booker, Congresswoman Alma Adams, and now more than 120 House and Senate co sponsors. The Momnibus, which I first introduced in 2020 with then Senator, now Vice President Kamala Harris, is a suite of 12 bills that build on existing legislation to comprehensively address every clinical and non clinical driver of this crisis. For example, the Momnibus includes policies to provide trainings on bias and racism to maternity care providers, ensuring that clinical care is consistently respectful and culturally appropriate for every pregnant person and new mom. But the legislation also recognizes that social determinants of health, like housing, transportation, and environmental conditions, also impact outcomes for moms and babies. The Momnibus includes funding to ensure that every mom has access to the robust social services that they need and deserve throughout pregnancy and for the full year-long postpartum period and beyond. One of the most important social determinants is nutrition. And there's robust evidence proving that the WIC program, which provides nutrition support to women, infants, and children, improves health outcomes for moms and babies and even reduces mortality. However, many families that need WIC the most don't have access to these benefits. The Momnibus would extend WIC eligibility in the postpartum and breastfeeding periods, ensuring that new moms and children can receive the nutritional support they depend on. The Momnibus also includes provisions to support women veterans and incarcerated moms, as well as people suffering from mental health conditions or substance use disorders during or after pregnancy. There's also funding for data collection enhancements and digital tools, investments in the perinatal workforce, and policies specific to COVID-19. These are necessary investments that will save lives and support families. And I look forward to working with my Democratic and Republican colleagues in the House and Senate and the Biden Harris administration to get the Momnibus signed into law because every mother deserves access to the care and support they need during pregnancy, throughout labor and delivery, and for the full year long postpartum period and beyond. So, thank you for shining a light on these issues, and thank you for all the work that you do and will continue to do to save lives. I'm so honored you invited me to join you for this event, and I look forward to the day that we're back together again in person. But until then, take good care of yourselves, everybody.
On behalf of the Alliance to End Hunger, I want to thank Congresswoman Underwood for her leadership in addressing the maternal health crisis. We are particularly excited to learn more about the Momnibus Act and especially to learn more about its direct connection with improving access to the WIC program, as we believe that that is an important investment in ensuring equitable access to healthcare and nutrition. As we will hear today, ensuring equitable access to healthcare and nutrition for all will require a multidimensional approach. That is why we are excited to be joined by such a diverse group of panelists who can speak from each of their unique perspectives. We are joined by Dr. Kanika Harris, Director of the Maternal Health at the Black Women's Health Imperative, Kate Summerfield, President, Social Determinants of Health Institute at ProMedica, and Darlena Birch, Senior Public Health Nutritionist for the National WIC Association. We will first hear from Dr. Harris. Dr. Harris is a behavioral health scientist with over 15 years of experience working in academic, nonprofit, government, and philanthropic sectors. She possesses a wealth of expertise in social determinants of health and brings a social justice lens to investigating the current health issues. Dr. Harris, the floor is yours.
Hi, everyone. That unmute thing always gets me. Good morning. Very happy to be here and to speak today on the behalf of the Black Women's Health Imperative. I'm honored to be amongst these esteemed panelists as well. And first, I will just start off giving a background of the Black Women's Health Imperative and what we do. Since 1983, we have been dedicated solely to improving the health and wellness of our nation's 21 million Black women and girls, physically, emotionally, and financially. So what does that mean? Just to give you some background in terms of the history and my introduction to the Black Women's Health Imperative. I was a little girl, right in that pre-tween stage. And Billie Avery, who started the Black Women's Health Imperative, she had a video called Unbecoming a Woman. And she nationally viewed that video. We were able to see it across all historically Black campuses around the nation. I'm a native Washingtonian, still live in Washington, D.C. And I was one of those little girls in 1987 that got a chance to see that video. And it was life-changing for me because the video on Becoming a Woman was a conversation with moms and daughters just about menstruation and reproductive health, sexual health, et cetera. And during the time, of course, in the 80s, there was this idea of this epidemic of teen pregnancy, especially amongst Black girls. And so for mothers to have a tool to talk to their daughters about sexuality and menstruation and what that means was life-changing for me and my family. And lo and behold, it's always sparked a career for me, or an interest, I should say, in reproductive health and justice and what that looks like, what that means. And so to now be the director of maternal health for Black Women's Health Imperative is really an amazing honor. So just to give you an example, that's the kind of work that historically has been done. It's really about listening to Black women, listening to the stories and translating the lived experiences of Black women, and really getting to the root of the violence that we're seeing happening to us, in this case through maternal health in the United States, but we also look at chronic diseases. We have a program that has been going on for a long time for diabetes and diabetes awareness. Change Your Life, Change Your Lifestyle. We are in reproductive health with My Sister's Keeper that has programs across in several historically Black colleges working with young women about taking control of their health and learning about reproductive justice. We are working heavily right now in the policy realm, also within rare diseases. And so this is just a little bit of the work we do. And we've also started a huge anti-racism campaign that we are unveiling soon called Blinders Off. So that's just a little bit of a touch of the work that we do. And I'm gonna go a little bit into maternal health and where we are. Congresswoman Lauren Underwood summed it up wonderfully. And so I feel like sometimes we are starting to get really numb by hearing these statistics over and over again, and also feeling a little helpless about how stark they are. And I like to bring perspective into what these statistics really mean instead of giving you all a whole bunch of numbers all over again. So some of the interesting statistics that always are gut-wrenching and just hit me every time and motivate me to act is when I hear that author Nerissa Smith I think it was in the Times magazine, how racism causes childbirth to be a death sentence for Black mothers. And she so geniusly was able to look at the death of Black mothers and compare them to the top deadliest jobs in the United States. And so when you look at that and you look at the comparison, to give birth in America for a Black mother would be the 5th deadliest job in the United States if it were an occupation. And that's really striking. It's more deadlier than being a log worker, than being a fisher out in the sea for, I don't know how long they go out, for 3 months to 6 months at a time, than being a pilot, and then being a roofer. So, and then you have Black mothers. And so that's really, it's really just disheartening and just really shocking to hear. And then we also know, in terms of infant mortality, in 2019, the infant mortality gap was higher than during slavery. And that's another stark statistic that two economists, Michael Haynes and Richard Steckel of Ohio State University, concluded that in 1850, the infant mortality rate for Blacks was about 340 per 1,000 and 217 per 1,000 for whites. But in other words, in 1850, Black were 1.6 times more likely to die in infancy. But in 2016, Black were 2 to 3 times more likely to die in infancy than whites. So that racial disparity is really starting to know that we've gone so far left that during a time where we had no autonomy over our bodies, where we had no rights, that the infant mortality rate, and when you think about what we're talking about today, even nutrition and what you needed, we were more viable in slavery than we are today. So I want to talk about COVID a little bit and where we are today in terms of Black maternal health, especially during COVID. And I want to take some time just to think of Dr. Susan Moore, who died during COVID, and just how, when you go back, if anybody has ever wanted to traumatize themselves and listen to her video and just listen how much pain she was in, how she just, as a doctor, knew what was happening to her body, was able to articulate that as a physician. And she was not believed. She had to transfer hospitals. And when she transferred hospitals, she died. And so you're talking about a doctor, a physician, a Black woman. And just to know that you're not believed and dismissed, and your knowledge and expertise as a doctor is invalid, and you could not save yourself, then what chance does a Black pregnant woman have during COVID when she doesn't have someone to advocate for her as much, and when she doesn't have, and when, in the beginning of COVID, essentially you couldn't even have your partner in the room, and then you could have a partner. And now we're to the point now where I think you can at least have one more support person and a doula in the room. But you can see just with Dr. Susan Moore, what Black pregnant women are up against. And just in general, expectant moms are have a 50% higher chance of being admitted for pregnancy and getting admitted for pregnancy pregnant women are admitted, if they do get COVID, and a 70% higher chance of being intubated if they have COVID, So on top of that, Black women are more susceptible to complications from COVID. So we're just seeing, as we know, Black women are disproportionately affected by COVID. And so with that, pregnant moms are 50% have a 50% chance of being admitted in the hospital. And so there's just less advocacy overall, less protection against discrimination. We also see isolation during COVID. One of the most disheartening things about this, for all pregnant women, is that during COVID, you're isolated. This is the time you need the most support. This is the time that you need help with just having social support around you. When you have your baby, you want your parents to be there. They're not allowed to be there with you. So just from that perspective, knowing that Black women are also 2 to 3 times more likely to suffer for postpartum depression, situations like this under COVID definitely exacerbate those situations. So one thing Congresswoman Lauren Underwood did not get to mention in her presentation is that the Momnibus bill passed the House last week. So we are so excited about that. And just as she mentioned, now it started off with 9 bills and now we're at 12 bills to really dismantle racism and bias. And we're looking at that through through things like the data collecting bill, making sure our stories are heard. As we mentioned, strengthening health services for incarcerated women, nutrition, housing, healthcare, all of these. I'm sure, I think Kate will probably focus on social determinants of health. And I want to save that space for her in terms of how all of this affects pregnant women. And specifically the Black Women's Health Imperative, we are really focused in terms of policy, working very closely with the Black Maternal Health Caucus and also Black Mamas Matter and the Momnibus Bill on climate change, just recognizing that Black women are more likely to live in urban areas that are more affected by heat. In hot areas like Louisiana, Georgia, Florida, we are concentrated in those areas, and heat is a huge risk factor for preterm labor. And so looking at climate change, looking at what happens in cities where that heat is just concentrated between buildings, that is something the Black Women's Health Imperative is fighting for and focusing on within the Momnibus bill. Also looking at postpartum depression and just maternal mental health overall. We conducted a study with AWHONN, the Association of Women's Health, Obstetrics, and Neonatal Nursing. That always is a tongue twister for me. And with AWHONN, we recently did a study that we're working on a publication on, looking at nurses, implicit bias specifically amongst nurses. And just to wrap that up, what we found was just that not only were Black women more likely to have postpartum depression, especially if they had a traumatic birth experience. This was across the age range from age 18 all the way through, I think our oldest participant in the study was 46. And that they're more likely to be overlooked in the postpartum process. During their postpartum phase in the hospital, and then also gaps are missed in terms of their follow-up and struggling with postpartum depression. So that's something based on our research, we're now going to focus on in the policy area. And just in general, just to talk about where we're moving in terms of maternal health, reproductive health and reproductive justice is something that we've always focused on. And we are really expanding our strategies in terms of maternal health right now. And so some of the areas we're going to focus on is, of course, creating implicit bias and anti-racism evidence-based curriculum, but not really stopping there, understanding that that's not enough. But we also want to build out a program with an action plan that holds hospitals and clinics accountable. And they follow through an entire program, making changes as well. So it's not a check off the list, one-off training that we're doing in terms of implicit bias. Really focusing on, as Congresswoman Lauren Underwood talked about in terms of investment in prenatal workforce. And we're doing that actually fresh tomorrow. We're starting a doula training, postpartum training program based off of our research again, called Nourish, New Opportunity to Reclaim Our Resources, Intuition, Spirit, and Healing. And this is around really advancing that perinatal workforce to doulas, especially in the postpartum process. As Eric mentioned, to make sure that moms understand nutrition or educated about nutrition, get proper nutrition, amongst many other things and support that's needed postpartum. And we are also convening a research task force to address postpartum depression and address the skills to make sure that they are adequately capturing the needs of Black women. And also working, as I mentioned, strongly in the policy arena. So I will stop right there. I don't know if I'm at time, overtime, what, but just wanted to give my spiel today to all of you. Yes.
Thank you, Dr. Harris. You are at time. So
Oh, great.
Perfect
Awesome.
timing. And we appreciate your remarks and definitely appreciate your passion and your transparency of and also just talking about all the work that you all are doing at the Black Women Health Imperative doing. And we look forward to working with you all in this space to advocate on, particularly around nutrition policy and advocate how that impacts positively to African American women, particularly when they're pregnant and throughout birth. So look forward to working with you.
Thank you.
I would now like to introduce you to Kate Summerfield to provide us with a perspective from the healthcare field. Kate Summerfield is the president of the Social Determinants of Health Institute for ProMedica, a mission-driven, not-for-profit healthcare system based in Toledo, Ohio. ProMedica is the 15th largest hospital system in the country, serving communities in 28 states. Kate is responsible for shaping and leading ProMedica's work in the social determinants of health, including clinical integration, medical education and training, and strategic community initiatives. Prior to joining ProMedica, Kate worked for various community-based and nonprofit organizations, including the United Way Health System, the United Way system, leading both rural and urban change. Kate, take it away.
Huge thank you, Eric. Thank you to the Alliance to End Hunger. Thank you to Dr. Harris. An honor to be on the panel with you today. So I don't think we can start this conversation without front talking about the impact and committing to dismantling historical racism. And so when you look at the rates, whether it's in Ohio, where we see almost 3 times the amount of Black women's birth and death compared to white, you have to start to name it. So I think from a healthcare perspective, what we saw certainly since last summer and the murder of George Floyd, while this is not a new problem, you are seeing more and more healthcare systems, payers, and providers starting to publicly acknowledge it, to name it, and then really proactively work to dismantle it. And that's incredibly important. At ProMedica, we're on a long journey. We've got a long way to go. And we come to this conversation with humility and also really a desire to learn and to grow. I want to talk a little bit about our perspective just broadly within healthcare, kind of what we're seeing in trends, some of the work that we're doing locally, and some of the things that we're seeing, especially around COVID as it relates to nutrition. So we really take both a clinical perspective, obviously, and Dr. Harris provided a lot of statistics and examples of where we see disparate treatment. And we know that racial disparities, especially for Black moms, is significant from the time they enter our care within healthcare broadly, whether it's the primary care physicians, whether it's where you're actually birthing your child, huge disparities. And so really a commitment to make sure that we are providing and requiring and holding our leaders accountable for the care that they're delivering, they're providing, and how as a healthcare system do we make sure that the level of care is not only high quality, but it's consistent, right? And we know there's challenges there. We also do a lot externally as well. And so my work is around social determinants and thinking about those non-clinical issues, things like housing, food, transportation, that really drive overall health and well-being. And in COVID, certainly, again, these are not new issues. If anything, it really brought to light and started to exacerbate some of the disparities and need that we saw around nutritional access and education in particular. And we really take a two-pronged approach. So one, at an individual level, making sure that pregnant moms in particular have access to all the right nutritional support. So whether it's WIC access, embedding WIC clinics into our facilities, We deploy grocery stores, and we have a number of both physical bricks and mortar grocery stores. Interestingly enough, we just saw a rise, almost double the amount of SNAP dollars being accessed by a grocery store than they have in the last 12 months. So we're seeing a rise in SNAP usage. And hopefully that's converting into decreased hunger, although we have some more stats to work on and to look at that. We also do food prescriptions. So as a pregnant mom comes in to get care, for us, we're asking around nutritional education. As a mom screens positive for food insecurity, we use the 2 hunger vital sign, we're actually prescribing food as medicine. So just like we would prescribe a specific medication or procedure, we're actually prescribing food as medicine. And in those prescription models, again, they're during COVID, obviously, really concern around transmission rates. So we were able to quickly pivot and provided both front door pickup. We were able to have COVID safe environments and make sure that pregnant moms that needed nutrition and they get an additional supplement for food were able to really receive those benefits during COVID. But really significant challenges, even as it relates to formula and breastfeeding knowledge as well. So I think both at an individual level, making sure that from a policy perspective, the right supports, education, breastfeeding all the way through until the child is older, but also at a community level, how healthcare and community partners can work together to make sure that there's high quality, safe, affordable housing, access to food, transportation resources, right? They're all linked. And so while hunger and nutrition is critical, you can't solve one without really understanding the impact that something like a strong public transit system has in your ability to access either your WIC, SNAP, grocery, and so it really is all interconnected. So a lot of work, again, I think, I'm encouraged, I think, by where we are in the acknowledgement of the challenges we have, the commitment to education, but we still have a long way to go. We also deploy community health workers. And so using a culturally proficient model, deploy community health workers who are based in community and who are paired up with pregnant moms. And what we see when we're able to connect with a pregnant mom from her first trimester on, we actually see racial disparities decrease, which again is promising, but it requires that we're identifying and being able to connect in that relationship building way. During COVID, our community health workers were not able to have face-to-face visits because of the difficulty there. And so did a lot of phone work. We did a lot of home visits from the yard and got really creative, but the isolation that Dr. Harris mentioned, the behavioral health concerns definitely rose. And so our ability to connect with moms, to build those relationships, and then make sure that we could provide the right supports from access to quality care, definitely was a challenge during COVID. And still, I think the fear is out there. A lot of work happening around COVID vaccine programs, but there's still a lot of fear. And so how as healthcare and community partners we build relationships, make sure we're connecting in the right ways and providing the right resources. Again, I'm encouraged, but we still do have a long way to go. So a huge thank you again to Dr. Harris and the Alliance for the opportunity. I'm again encouraged that healthcare is at the table and that we're really hopefully committed in showing the progress, whether it's implicit bias training, whether it's making sure that we're actually investing in things like grocery access programs, food prescription programs, that we're committed to making sure that we're embedding SNAP and WIC supports along with our clinical care. A long way to go, but on the right path. Thank you.
Thank you, Kate. Thank you for your thoughts, and we really appreciate the work that ProMedica is doing to help close gaps around and really making that connection between healthcare and nutrition. Now, last but not least, I am pleased to welcome Darlene Birch with the National WIC Association. Darlene began her career in the WIC program at the local agency level, working in rural communities on the Arizona-New Mexico border. She worked as the local agency's WIC director and registered dietitian before moving to the Arizona WIC state office in Phoenix. In a continuous effort to explore and expand her horizons, Darlene then moved from the West Coast to the East Coast, where she worked as the training center nutritionist with the Maryland WIC state office. Currently, Darlena's work involves representing the National WIC Association at stakeholder meetings, participating in advocacy efforts, and collaborating with National WIC Association partners, coalitions, and task force to promote and elevate the WIC community's nutrition and breastfeeding related successes and concerns. Darlene, I'll turn it over to you.
Thank you so much. And just give me one moment to share my screen so everyone can see my presentation. All right, so thank you again, everyone. My name is Darlene Birch, Senior Public Health Nutritionist with the National WIC Association, and I'm here to talk about the state of WIC and maternal and child health specific to this important federal nutrition program. And so for the first thing I want to highlight is give a brief overview of the WIC program. And the WIC program is essentially the premier public health nutrition program that ensures the health and well-being of program participants, which includes women, infants, and children up until their 5th birthday. And it does this through the provision of nutrition education, breastfeeding support, supplemental foods, and referrals to health and social services. WIC plays a role in addressing maternal mortality through nutrition. And although nutrition is only one factor in this complex topic of maternal mortality, strong nutrition can have a tremendous impact on reducing maternal mortality in the US. WIC addresses both micronutrient and macronutrient needs of the WIC population through its prescriptive food package, which is tailored to the specific life stage of the participant. Research has shown that WIC participants are more likely to receive adequate prenatal care. And in a recent study, researchers found that mothers who received the revised WIC food package had a reduced prevalence of both preeclampsia and excessive gestational weight gain. Findings from outside of WIC have identified substance abuse, lack of social support, homelessness, intimate partner violence, lack of prenatal care during pregnancy, and mental health issues as all factors contributing to maternal mortality. Therefore, it's through the services and referral system of WIC that the program plays a vital role in helping pregnant women who are at risk of maternal morbidity and mortality. Research has also shown that WIC reduces the likelihood of adverse birth outcomes, including very low birth weight babies, and it also improves the birth outcomes for high-risk mothers. Therefore, the long and short-term benefits of WIC cannot be understated, especially with regards to breastfeeding. And the short and long-term benefits for breastfeeding are also well established. Research indicates that breastfeeding can reduce the risk of certain diseases, including cervical and breast cancer and infections for both infant and mother. And therefore, WIC plays a vital role in helping to support these important health outcomes, both pre and post delivery for mother and infant through its support of breastfeeding within the program. For every dollar spent on WIC, there is a return on investment of $2.48. So again, I just really wanted to highlight how important this program is in helping to ensure the health and well-being of both women and children. Now, I do want to provide a high-level overview of what the National WIC Association is, and I'm not going to spend too much time on this slide, but the National WIC Association is the go-to voice of and for WIC leaders at the nation's more than 12,000 WIC clinic locations across this country. We provide member-driven advocacy, we educate, guide, and support WIC staff, and we drive innovation to improve and strengthen the program for over 6 million participants who participate in WIC. Our mission is to provide our members with tools and leadership to expand and sustain effective nutrition services for the participants. And our vision is a nation of healthier women, infants, children, and their families. So now I want to talk more about the state of WIC within regards to maternal and child health. And as the previous two speakers have highlighted, as well as Representative Underwood, discrimination, racism, and stress are all linked to inequities in maternal and infant mortality. And so at the National WIC Association, we've done a lot to take up this cause and find ways in which we can help address these disparities. So I now want to talk about the way in which WIC can address maternal mortality through a suite of services it offers. And the first one I want to highlight is through community partnerships. WIC helps to address maternal mortality by participating in the community through forming partnerships, hosting events, and conducting research. WIC staff are also often members of the community themselves, and WIC clinics build partnerships with local birthing hospitals and OBs to better coordinate and support women during pregnancy, which allows for provision of continuity of care. This also helps pregnant women with expectations for care in the hospital during delivery. But one of the biggest things that we're focusing on at NWA with regards to community partnerships is the streamlining of services, as a majority as a major priority for WIC participants. WIC serves only 51% of the total eligible population. And so while a major focus for the program currently is retaining children as they age, another particular challenge for us is onboarding pregnant women as early as possible. With regards to health assessment, WIC appointments involved health assessments that serve to identify existing health conditions during pregnancy, while also connecting women with primary providers to assist in and manage conditions during pregnancy. I've highlighted breastfeeding a little bit, but I want to talk about it in more detail here. WIC educates participants to help ensure successful breastfeeding, thereby creating strong mother-infant bonds, while also providing early support of maternal health postpartum. And it's through our breastfeeding peer counseling program, which was mentioned earlier by Representative Underwood, that this program connects women with peers in their community prenatally and postpartum for breastfeeding support and other nutrition education, such as group classes. The breastfeeding peer counseling program in particular has been shown to improve breastfeeding rates among Black women participating in WIC. Nutrition education services are another aspect through which WIC addresses maternal mortality, and it's through individual nutrition assessments and counseling that's provided during the WIC appointment that helps to meet the woman's goal and interests. The WIC nutrition education services also provide support for healthy weight gain during pregnancy and postpartum, including the interconception period. And because these services are provided at no cost, WIC removes and reduces the barriers and challenges that low-income pregnant women often experience when receiving services. I want to end this slide on referrals to health and social services because WIC provides referrals to preventative health and social services while also following up with program participants. It plays a vital role in bringing attention back to the mother and providing necessary referrals. And one thing I do want to highlight is that oftentimes WIC participants, postpartum women, are coming in to see their WIC provider before they go in for the postpartum checkup. So it's a really vital, I guess like safety net for moms being able to come into the WIC clinic and get those referrals and to make sure that not only their nutrition needs are being met, but their other healthcare needs are being met as well. Therefore, WIC's referral services help to improve prenatal and maternal health, specifically through its provision of substance abuse counseling, shelter, and housing referrals. But now I want to move on to discussing how WIC was impacted through the COVID-19 pandemic. And the biggest thing that I want to highlight is how the WIC program basically was able to really meet participant needs through remote certifications. So because multiple state agencies reported clinic closures, it was imperative that state agencies developed procedures to establish remote certifications. And therefore, WIC clinics across the nation were able to certify new and existing participants by phone, video conference, and through online forms. And so that's really what I want to focus on for this slide. We were also able to help meet needs through remote issuance of supplemental benefit of the supplemental foods. And the last slide that I'm going to talk about today is just ways in which WIC has these policy solutions to help address maternal mortality, specifically with the disparity seen within Black women. And so as Representative Underwood touched on earlier, so I'm not going to spend too much time talking about the Black Maternal Health Omnibus, but there's the suite of the bills that will come through. And this piece of legislation is key, obviously, in supporting women during pregnancy and the postpartum period. So NWA is in 100% support of this the omnibus, as we've worked tirelessly through our public policy team to make sure to help get this legislation pushed through. What I really want to spend a little bit more time talking on with this slide is the WIC Act, also known as the Wise Investment in Our Children Act. And this was introduced by Senators Bob Casey and Susan Collins. And there's three pieces to this act that would really help to address maternal and child health. The first piece is that it would extend child eligibility. Over half of the children entering kindergarten are at least 5.5 years old, and WIC only serves up until the 5th birthday. Once a child turns 5, they are no longer eligible to participate in the WIC program. Therefore, when children lose eligibility for WIC on their 5th birthday, they could go months without receiving nutrition support that is provided through the school meals program. And so by extending the child certification to 6 years of age through the WIC Act, it would help to cover this gap that we see with children who are above 5, but not yet in kindergarten yet. A second piece would be to extend postpartum eligibility for 2 years. For women, right now it's at 1 year. And WIC's nutrition support can play a vital role in supporting the nutrition needs of women during this interconception period, ensuring a healthier start for subsequent pregnancies, because even though this would be postpartum certification for 2 years, it is also pre-pregnancy, nutrition education, because many of our WIC participants, this isn't going to be the last child, or it's not the first child that they've had in the program. And so really expanding extending the postpartum certification period would be monumental in helping us address this. The last piece would be to extend infant certification periods to 2 years. And this is just a way in which we can help really decrease some of the burdensome paperwork that comes in with WIC. And one thing that I also wanted to mention earlier with, it's really important for us to be able in the WIC program to streamline services and be able to touch base with other programs like Medicaid, being able to share information. We often find that WIC participants come in and a lot of the paperwork that they are sharing to get certified into the program, they've already brought elsewhere. And so if there was a better way in which, the WIC clinics can communicate with the participant's healthcare provider to maybe get like heights, weights, a way to kind of discuss more of that type of information, as well as, certifying information such as income, proof of residence, it would really help, really alleviate the burden of the participant having to bring that stuff in, that which ultimately would also, discourage participants from wanting to be in the program, because it does make it more burdensome for them. And the last thing I want to talk about is the WIC food package. And so the WIC food package, as mandated by the Healthy Hunger-Free Kids Act of 2010, undergoes review every 10 years. And so the most recent review was completed by the National Academies of Sciences, Engineering, and Medicine back in 2017. And so we are at NWA working tirelessly to help push through those recommendations, which are now in the hands of USDA, who will choose which recommendation should be implemented into the WIC program itself. And so these recommendations that NASM pushed forth back in 2017 would really help to meet the nutritional needs of the WIC participant. It also calls for better cultural diversity within the WIC food package, just to help meet the diversity of dietary needs that come across the WIC community. And so, making those changes to the WIC food package also help improve the health outcomes of all participants within the program. And so if anyone has any information, this is my contact information. And I want to thank everyone so much for giving me time to participate in this convening.
Thank you, Darlene. We really appreciate you participating in today's panel discussion and providing all the information that the National WIC Association is doing, and talking specifically about some of the policies that you all are supporting. And I'm sure we're going to go into a little bit of detail in some of those policies during the Q&A, which leads me to this portion of our panel, the Q&A portion. As a reminder, please feel free to enter your questions into the Q&A box at the bottom of your Zoom screen. So let's just jump right in. I'm going to start with the first question. This is for all three of y'all. Feel free to answer if you feel so. Can you please speak on the importance of bolstering our nation's health and nutrition preparedness with special attention given to pregnant women and children? We talked a lot about how this is important to create positive health outcomes. I just love for us to maybe expand on that a little bit.
Yeah, maybe I'll jump in. So for a long time, I think healthcare is starting to really recognize that hunger is a health issue. And so while we think about nutrition, obviously a lot of individuals, WIC and SNAP, food banks and supports are there. It is really a critical clinical issue. And so the integration of nutrition into how we deliver care is really gaining momentum and gaining traction. We know that whether a mother has healthy, affordable food, right, is key, especially both preconception. And so a lot of work happening across the country to make sure that women of childbearing ages are healthy, have the right nutrition, but then certainly as she goes into her pregnancy and then postpartum as well. And so from a physical health standpoint, we can start to link the impact and the ability of a mom to have healthy food to the baby's outcomes. And so whether it's either looking things like lead poisoning, we're seeing more and more trends, unfortunately, tick up around pregnant moms who've been exposed to lead. Some indication from research that there are certain foods that can actually help reduce some of the lead exposure. So really, it's a really important health and well-being. Both primary care docs, our EPPs, our physicians, and our clinical staff have really started to embed nutrition supports to make sure that at the time of care, whether that's the first trimester or around delivery or the postpartum visit, that this is starting, we're asking the right questions, we're asking around food insecurity, access to healthy food, and then we're working to connect to the right support. So whether that's WIC or SNAP, we know during COVID, there were a number of different food supports that popped up around the country. So whether it's food pantries or food banks, there's been some really innovative models around food delivery programs. So as you take out bricks and mortar stores, how are we providing healthy, affordable nutrition at the doorstep? And so really interesting startup businesses are starting to pop up. You're seeing more and more both Medicaid providers and some commercial providers actually starting to fund health and nutritional services. So a really interesting time, I think, as you take existing expansion and really supports that we need around the federal programs and WIC and SNAP, combined with some of the things that we're seeing from healthcare starting to fund, and then some new businesses, a lot of innovation happening in the food as medicine space as well.
Darlene, I didn't know if you wanted to jump in. I'm happy to go before or after.
Feel free to jump in.
Okay, sure. Just based on what Kate is saying and to bring perspective, and in terms of some of the gaps, right? Because we know that we're providing these services and they're available, but then we have, as we know, to make sure that translates for those who need it most, especially most marginalized populations, in terms of what does it mean to have healthy foods? And when you're asking those questions, do you essentially know what healthy foods are and what that looks like? Are we planning on enough time within our doctor's visits to make sure that those type of questions are addressed? And Darlene, you shared some interesting statistics around preeclampsia, and just from personal experience of being a doula and being a mom who I had preeclampsia once, and then I was at risk of having it again. And just, this is about that implicit bias training and better information with doctors, because both times that I had high blood pressure during pregnancy, I was told that there was nothing nutritionally that I could do, that it is what it is, and just try and take a baby aspirin, and that's the best you can do. But I know by controlling my nutrition and really focusing on low salt foods and drinking lots of water, et cetera, that second pregnancy, even though I was always at that borderline in terms of having high blood pressure or having hypertension, I really felt like it was my diet that really controlled that. And what kinds of foods are we giving? Like, is it what's accessible? Because if we're getting a whole bunch of canned foods and processed foods, we know that when you're pregnant, that's probably high in sodium. So like, I think all these things still have to be really, really fleshed out in terms of what we're providing, how we're providing it, and the conversations we're allowing, especially in terms of that training that we're getting, and making sure the conversation about nutrition in terms of WIC and what we have also matches what physicians are doing, and especially what they're learning in medical school, because when you look at nutrition, it's a very short part of medical school, unless you're going into some specialized section of nutrition or you're becoming a dietitian. And then for lactation, there's no lactation training at all for physicians. Like, they don't get any training in terms of lactation. I'm on the Lactation Commission in DC, and that's one of the things that we're trying to deal with, is that physicians inherently, because of their training, not inherently, but really just because of training, they don't get that lactation nutrition to understand how to connect the dots that we're talking about. So how can we do a job of making sure all of this information is coming together more cohesively and translating to those that need it most?
Yeah, thank you so much, Dr. Harris. Really appreciate what you had to share. And I think for us specifically with regards to this question at NWA, for us, the biggest thing is just finding ways in which we can integrate telehealth and make it more convenient for moms, because if there's one thing that this pandemic showed for us is that we need to be able to meet our participants where they're at and provide them with flexibilities and options. One of the best things that we actually learned from this pandemic was that prior to the pandemic, no-show rates, like the number of participants that would not show up to their appointments, was incredibly high. But with the advent of having to transition WIC to these virtual appointments, the no-show rates have dramatically declined, because, you look at the barriers that a lot of our participants have to deal with: transportation, time, just trying to juggle like life and trying to make sure that they also make it to their WIC appointment. So, trying to make sure that we can keep this type, being sure like that we can provide those virtual flexibilities to participants even after the pandemic, recognizing how much more accessible it made the program, is going to be very key for us moving forward.
Thank you all. Here's a question from the panel in reference to the WIC Act. Can any of these provisions be done on the state level?
Yeah, so I did. Thank you so much, Hope, for asking that question. And so the way that the WIC program works is that, a lot of the legislation and the federal regulations for the program are made through Congress and implemented through USDA. And so USDA sets the policy nationally for the WIC program, and then state agencies adapt that policy, and they can make their state level policy more strict, but they can't make it more loose. And so there really has to go through Congress in order for the, the program to extend to age 6, in order to extend that postpartum eligibility to 2 years, and in order to extend that infant certification period. So it would be great, if it could be done at the state level, but it has to go top down first. So first, Congress needs to change the federal regulations for the program, and then states can make those changes. So thank you for that question.
And while you have the floor, one more question regarding the American Rescue Plan. The American Rescue Plan temporarily increased fruit and vegetable allotments for WIC. Can you talk a little bit about the impact of this?
Yes. So we are incredibly excited to see that was passed. So currently in the WIC program, participants will get either $9 or $11 on their cash value voucher. So that's the vehicle in which they get a dollar allotment to buy the fruits and vegetables in the WIC program. And so with the American Rescue Plan, we've been able to triple that value to $35 for all participants across the board. And our public policy team worked tirelessly to get that pushed through. And so it's basically, I actually did see that question through and sent a text to my public policy colleague, so give me a second to read his messages, but he's saying that enthusiasm is through the roof. WIC participants across the nation are incredibly excited to get this additional money, and we have actually been holding convenings with WIC participants across the nation these last couple months. And when we were asking for possible changes to the WIC food package that they felt would be like beneficial, the cash value voucher increasing that dollar allotment was hands down a universal request from our participants. So getting that to $35 has been well received by participants and WIC staff alike. And we know that this will lead to better health outcomes. And we're hoping to make this a permanent change in the forthcoming USDA food package review, which I mentioned earlier in my presentation. And so I believe that it goes into effect on June 1st, but some states have already started implementing this increase, including Arizona, Georgia, Michigan, and Ohio. So yeah, we are incredibly excited to be able to have those $35 for WIC participants, because frankly speaking, at 9 and 11, there's really not much you can get anywhere with regards to, those fruits and vegetables. So this will really help us improve the nutritional well-being of program participants.
And Darlene, I can just share, we operate a grocery store in what was a food desert, a lot of affordable housing around that. And we've seen a number of moms, the whole spectrum, but a number of moms in particular, we're seeing increases in that. And so huge impact that we're seeing as someone who operates a grocery store. So
Great, thank you so much, Kate.
And here's another question from the audience. Is there anything being done in regards to doctors being biased to Black mothers in regards to dismissing them? Like any type of training or some sort of education on implicit bias? I know you guys mentioned, you mentioned how, medical school training, how that's being done. I'm curious, has there been any curriculum in place at medical schools and other areas to try to better train doctors?
Yeah, so I can speak to, am I muted? No, I can speak to that. A huge part of the Momnibus bill is to have implicit bias trainings and to roll them out across the country. I think it was HRSA that I saw recently has a free implicit bias training out that's right now. And what I will say is that, I'm also the health equity advisor of maternal health for Maryland, and we're in these conversations right now. And I think one of the nuanced things that we're forgetting about these trainings that is like an aha moment for me is that America, the US is very international. So we have doctors that are coming from all over, right? To do their residency here, to train in here, nurses especially. So they're having their own perceptions of America and their biases on top of whatever we're coming here with and biases. And so we really have to look at these implicit bias trainings as they're gonna have to be very specific, and it's not so black and white, right? You have doctors that are coming from Europe, you have doctors that are coming from Africa. And I'll give you an example. I was in a conversation on a task force meeting, and one of the doctors called Black woman colored. And he called Black woman colored because he was from South Africa and he was Afrikaans. And colored is actually like an identity group in South Africa. And, everyone was upset. It was a horrible experience. And unfortunately, he was kicked off the task force. And so, but it just shows you that there's all kinds of cultural biases that we're bringing to the table, and that we have to do a better job of really looking at what these biases mean also from a patient perspective and the international perspective of patients that are coming from, patients that are immigrants that are here from all across the world, and what our biases do to them, as well as this black and white bias that we talk about. And so that's kind of what I'm working on. I don't know where it will lead me, but the aha moment was like, this is just not this clear black and white issue. And that if we're trying to train all doctors the same and teach them about biases all the same, we are going to miss so many. And that it doesn't stop there, right? Because doctors get tons of training. I did an implicit bias training recently for neonatologists and OBGYNs, and I had 2 hours to do this training, and I felt like I was talking a mile a minute because there's just so many layers to uncover. And so it really, but they got their credits, right? They got their continuing education credits, and they're moving on to the next thing. And I'm just realizing that I will not spend my time doing it that way again, that we just have to be more invested in something that's more sustainable. And like you said, we started earlier, as soon as you get in medical school, and it's continuing throughout, that you stay doing it. And that we're also seeing biases within the medical profession, right? So Black doctors and Black nurses are also experiencing racism trying to do their job, and the autonomy to do their job as well. So all of these things need to be uncovered, and it's not as simple as a one-off. So that was long-winded, but this is where my thoughts are right now around this topic. So thank you for that.
Yeah, thank you. I just want to follow up on what Dr. Harris shared, and for the WIC community specifically, with back in 2018, at NWA, we were recognizing that these issues, the health disparities regarding maternal mortality, with regards to essentially just racism in, the healthcare experience for certain populations, something needed to be done within WIC. And because WIC plays this unique role in being able to see women postpartum and catching them, and also walking them through their pregnancy, or helping them through their pregnancy, we convened a maternal mortality task force. And that task force worked to publish last fall both a full report and a position paper that essentially laid out the landscape of maternal mortality across the nation, and then talked about WIC's role in addressing maternal mortality. And one of the things that both the full report and the position paper particularly highlighted was racism and health disparities, how even other topics such as like ACEs will impact maternal health outcomes. And so what they put as a recommendation in this report, there was 12 recommendations that came out of it. Some of them also addressing just racial and health disparities, trainings that can be given to staff, because while we recognize that maybe overt racism isn't as common anymore, implicit bias does very much still exist. And these are things that, that we need to be able to address in WIC, as we're giving referrals to health and social services. How are moms feeling when they're, talking to WIC staff about their issues? Do they feel heard? Do they feel dismissed? And so our maternal mortality task force has worked tirelessly to try and elevate the importance of being able to educate WIC staff on maternal mortality, educate WIC staff on the disparities, particularly among Black and Indigenous women, and then, ways in which these WIC can help close this gap to improve the health outcomes of these mothers and the children as well.
Let me just do a quick shout out. Dr. Maybank joined the American Medical Association, I think in 2019, just doing tremendous work and really helping physicians around the country and the medical association rethink and roll out trainings and support. So if you've not heard Dr. Maybank speak, would definitely do a big plug and push for her. She's doing really incredible work over at AMA.
Thank you so much. Another question, what are some opportunities to fund food is medicine for pregnant women and young children through healthcare in a sustainable way?
Maybe I'll jump in really quickly. So one of the things that we're working on all of our social determinant supports is starting to really understand the impact as it relates to health outcomes, cost, and utilization. So if an individual, a pregnant mom, for example, were to come in and is struggling with finances, we work to help stabilize our credit, increase credit scores, build wealth over time. What was the impact of that financial support as it relates to her health? Is she healthier? Is she in the right care, right place, right setting, at the right time? Are we seeing cost reductions? And so for our food prescription program that I mentioned earlier, where we're actually prescribing food as medicine, and for pregnant moms, that's a specific support. It's 3 days of food for the entire family. So it's not an entire month, but it is 3 days for the family. We're measuring that impact of the food prescription program as it relates to, again, her utilization and her cost for both the individual mom and for the baby over time. And what we see is when she's provided support for 12 months, we actually see cost reductions. So we see cost reductions around ER usage, cost reductions around PMPM, which is a per member per month, and increases in primary care. So she's coming to the primary care setting more often. And so I think it's data like that really for healthcare, both payers and providers, to start to understand here's the impact of food and nutrition can have in very concrete ways. And the more data, as we build that evidence base of here's the impact as it relates to cost, more and more healthcare payers, providers, and partners will start to fund this work. You're starting to see some pretty big shifts, whether it's CMMI, some carve-ins around for Medicare and food. Some number of Medicaid plans at the state level are starting to actually allow for food to be supported. So that's just, I think, again, a good example, some early momentum, but it's really going to take more evidence to link health and nutrition specifically to health outcomes and cost.
Thank you. Kate, you mentioned earlier about some of the barriers that particularly mothers and particularly mothers and children in lower income communities have, whether it's transportation, housing, other things. And we talk about COVID and how COVID has really exacerbated a lot of the disparities that we've seen. Can you talk a little bit more about some of the solutions to maybe closing those barriers? I'm particularly thinking about, all the conversation that you hear in Congress right now is around infrastructure. We often think of infrastructure as building highways, bridges, and roads. But I know that there are a number of us in the community are looking at the social aspects of infrastructure. We mentioned community health workers, et cetera. But can you talk a little bit about what are some of those solutions to closing those gaps for folks who live in communities who don't have access to transportation or access to the doctor right down the street, particularly in rural communities and some of our urban communities where there are a number of food and medical deserts. Can you just talk about what were some of the solutions to closing those gaps?
Yeah, thank you, Eric. And I'll relate to both something Dr. Harris and Darlena had said earlier, actually around health literacy. So we took a look during COVID for individuals that had COVID, those that were hospitalized and those that were not hospitalized. And we started to look at the social differences between them and where they live. And obviously we see race, significant stats around both hospitalizations and death nationally. What was interesting from our data, and again, this is our data set for our patients, we looked at economic climate, so the level of wealth in a neighborhood. We looked at the food landscape. So were you living in an area with a food desert? Did you have access to high quality food? We looked at housing environment, and then we actually looked at health literacy. And what we saw is the greatest impact, whether on COVID hospitalizations, from a correlation perspective, so certainly not causation, but correlation, was actually around health literacy. And so Dr. Harris mentioned, do you have access, but do you know how or what things you should be eating as it related to preeclampsia? And so it was really an interesting trend. Honestly, digital divide, health literacy had not been on a radar pre-COVID. And I think Darlena mentioned also telehealth. So how are we providing telehealth supports? And so I think both isolation, health literacy, digital divide are really going to be trends when you talk about infrastructure supports. We've got to think about how we provide services and programs and supports differently, whether it's health literacy, we're providing the right training, and there's obviously the access component, but there's also an education piece as well. And so from an infrastructure, digital divide and health literacy are definitely on a radar that previously pre-COVID had not been something we were focused on. We've since been embedding both health literacy and digital divide into our screening. So in addition to asking food insecurity and housing and transportation questions, we're now asking questions around digital divide and health literacy. I think one of the trends that will help us from a policy and an investment perspective is to really start to understand more. When you say health literacy or digital divide, what does that actually mean? And what are the policy recommendations and investments that should support that? So I think, again, those are just two examples, a lot of conversation around infrastructure. There are some new pieces, especially as it relates to digital divide and health literacy that COVID really brought to light. And now we've got to figure out how to solve that and what the right supports are.
Anyone else want to chime in? Cool. All right.
Well,
Dr. Harris?
no, I was saying she covered it well.
Okay. Well, while I have you, Dr. Harris, can you share more about your national health policy agenda for Black women? The work that Black Women Health Imperative is doing around that?
Sure. You're going to stump me a little bit because that's like the policy teams, but I will do my best. So yes, we put out a national agenda, a national policy agenda for Black women, really addressing all facets of Black women's health, dealing with racism and discrimination, dealing with chronic diseases, reproductive health in terms of maternal health falling under reproductive health. And each of the areas that we focus on really have pillars to address those areas, and then also policy objectives to address those areas. So I can't speak. We are vast. We work really hard at the Black Women's Health Imperative on so many different things. And sometimes it's hard to catch up with who's doing what, but I can tell you we are on the ground working hard, especially one of our hallmark programs, again, are the diabetes program that really focuses on change your lifestyle, one of our longest running programs with Black Women's Health Imperative that comprehensively addresses diabetes, and then addressing other chronic diseases with policy agenda related to that. The whole report is on our website. So if you go to, I'll put it in the chat, our website, it's the first thing that will pop up for you to read and take a look, but it's about a 70+ page document that's extensive, and that includes our entire policy agenda for Black women, especially around anti-racism. And also, one of the things that we forget in terms of being healthy and having the autonomy to live your life in the way that you want is just really around like financial health and understanding financial literacy and understanding the gap in terms of the work gap and salary gaps for Black women, in terms of how we're disproportionately affected in terms of having the finances to live our life. And that's another important part of this policy agenda. So I really ask you to take a look at it, and someone so nicely summed up a little blurb about it in the chat. So I really appreciate that as well.
Well, on that note, I want to thank each of our panelists for their thoughtful contributions to this conversation. I really think that each of you highlighted the complexity of this issue while still recognizing that we do have strategies and policy solutions to put forward. But before we wrap up today, I would love to hear from each of you one last time on the key takeaways you hope our audience leaves here today with. So if each of you don't mind taking a couple of minutes, some of your final thoughts, that would be great. Let's start with Kate, then Darlena, and then Dr. Harris. You can wrap it up.
Oh, Eric, you're going to put me on the spot. Okay, yes, I'm going to go last. Well, just a huge thank you to the Alliance and to the panelists. Amazing work happening around the country. I think in this moment, it continues. We really have to keep looking in the mirror and figure out from an investment perspective, from a policy, how do we do more? When you look at the stats on where we are, either at a local level, a state level, or national, we're not trending in the right direction. And so what we've done up to this point is insufficient. And we have to keep continuing to partner, to work together, to listen to with humility, but really drive concrete change and really hold individuals, organizations, our elected officials, our healthcare leaders accountable. Again, from a stat perspective, it's just simply not enough. And so how do we strive to do more? How do we actually do more? And how do we put that into practice? So again, huge thank yous to the Alliance, to the panelists. Great to be with you. It was an honor. Thank you, Eric.
And yes, I echo Kate in just thanking the Alliance and, my fellow panelists and the attendees for, giving us this space to discuss this important topic. And I think some of the key takeaways that the National WIC Association, again, wants to elevate is just that the WIC program is the nation's premier, public health nutrition program. We serve such a critical role in helping operating as another safety net that just helps to ultimately ensure a healthier generation, because we are, providing nutrition support at the most critical time, in a child's life. Those early years are so fundamental in just building like that strong base, as well as, providing the appropriate nutrition support to pregnant and postpartum mothers. And so recognizing this critical role that we play as a program, I just want to elevate the importance of ways in which WIC and the National WIC Association can collaborate with partner organizations and partner programs to help just streamline services and be able to meet participants where they're at, whether it means virtual visits, whether it means recognizing what disparities and what, ultimately barriers they're facing, and just recognizing, the importance of addressing these issues, because at the end of the day, what we're trying to ultimately do is build a healthier nation. And so another key takeaway that I want to highlight is the WIC Act, and any support and partnership that we can get in pushing this legislation through, because it will also help us better meet the nutritional needs of program participants.
So I just want to say thank you so much, Darlena and Kate. These are exactly the conversations that we need to be having. We need to know about each other. The way I see Black Women's Health Imperative fitting in with the organizations that Kate and Darlena represent is that making sure that that information gets translated for Black women, that it really, that the intent actually meets the impact in terms of getting the resources out, getting Black women the nutrition that they need for pregnancy and beyond, making sure the information and how we serve Black women is respectful. We're not talking down to them. I'm really so pleased to hear about the trainings that are also happening for WIC officers, to make sure that, because if we're not talking to women appropriately and we're dismissing them, then all the resources and money that we're doing invested in WIC, we can't get that 50% that Darlena mentioned in terms of eligibility up, because the last thing you want to think of when you go to WIC is feeling like you are less than. And so how can we change that perception and make sure that these resources are utilized in a way that's actually supporting Black women? So I'm happy to be on this panel. I've learned so much from the both of you today about what we can take back to the Black Women's Health Imperative and the work that we have to do to make sure that we are cross-collaborating and this information and the resources actually work and support Black women and their families.
Well, I'll just take a few moments just to really, again, thank all of you for your comments and your expertise. Dr. Harris, Lena, Kate, you guys have really inspired us and given us a lot of great information to take back with us. As was mentioned before, more needs to be done. This year, Congress is expected to look at a number of pieces of legislation that addresses maternal and child nutrition. We just talked about the Omnibus Act, which passed the House, now has to go through the Senate. And so for those of you who are in support of that legislation, we urge you to call your senators and urge them to pass the bill. We also talked about the WIC Act, which is another key provision that members of the Alliance to End Hunger support. And altogether, Congress is also looking at reauthorizing overall our child nutrition program. So that includes not only WIC, but also our summer feeding programs and other things that are important to children, not only from through pregnancy, through the first 1,000 days of life, but also going into school and as they go through school. So there are going to be a number of opportunity and touch points where we will ask this community to reach out to their members of Congress and push for policies that not only improve and expand these programs, but also ensures that these programs are equitable and ensure that these programs are impacting the communities that need it the most. We do not want to leave anybody behind. We want to make sure that those gaps are closed.